Welcome to the 17th VPS Research Spotlight. This afternoon, we have two individuals, Dr. Christine DeMayo, who is currently a fellow in the Department of Pediatric Critical Care Medicine at the Ann and Robert H. Lurie Children's Hospital and Northwestern Feinberg Medicine in Chicago. And she is also her mentor, Dr. Anthony Sochet, who's an associate professor in anesthesiology and critical care medicine at Johns Hopkins University All Children's Hospital, are both with us today. So I'd like to welcome them. Dr. Sochet, who is Kristen's mentor, and by the way, she has had 3 publications already as the first-year fellow, so she's doing quite well. And Dr. Sochet, I should add, as an associate professor, has done extremely well himself. He currently has, as near as I can tell, 3 NIH grants, 2 R01s, and a K23 that he's involved in. So welcome to you both. I think with that brief introduction, we're going to move into the presentation, and then please note that we'll have some time for questions and answers during the end. If you please would try to put some of those in the chat box while we're moving forward, it would speed up things at the end because we have a relatively short time frame. We try to limit this to the 30 minutes. So, Kristen, let's hear about diabetic ketoacidosis and venous thromboembolism, a North American Virtual Pediatric Systems Registry from 2014 to 2023.
Sure, Tom. Thanks for having us. Would you like me to share PowerPoint from my end? Okay.
Sure.
Very good. Oh, I have to send a request.
Welcome, everybody, and thank you for being present for our presentation. Kristen, I apologize if you're presenting and I say next slide in a demanding way.
That's all right.
I would do it for you if we could turn it over the other way, but I appreciate you.
Absolutely.
Okay, screen's coming up from our end. There we go.
All right. Very good. So, so Dr. Sochet and I will talk about this in 2 sections. We'll talk about our study, diabetic ketoacidosis and venous thromboembolism, a North American virtual pediatric systems registry study. We have a good team of us that I'll also give some shout outs to towards the end of this presentation. But Dr. Sochet is going to start the presentation here and give us some background. And here is our the poll, the screen grab from PCCM journal, just to give it a little bit of boost there. Here's our disclosures. So there we had some funding from the Johns Hopkins All Children's Foundation. Dr. Goldenberg also received some funding from some institutions for his own research as one of our advisors and senior folks on our paper. And then Tony already alluded to, or you already alluded to some of Tony's funding here. And then otherwise, we don't have any other disclosures.
Awesome. If you want to click through and kind of show the slides, that's fine too. Before we talk about VTE, and we'll call it venous thromboembolism VTE from this point forward, there's a lot of word salad and acronym soup with relates to the terminology. And so when we say this, we mean pulmonary embolism, DVT, and organ-specific VTE, which includes heart, chest, lung, and other organs. Next slide. And when we think about their presence in children, we know from data from Leslie Orfini and updated by Sarah O'Brien that the rates of VTE in hospitalized children have increased by actually 200% in the last 2 decades. And amongst critically ill children, that rate is about 2.2%. And for high risk or considered high risk for VTE groups, you went backwards, but please go forwards one, is about 1 in 10. And those risk factors are pretty parsimonious across different pediatric subgroups, which we'll talk about in the next slide, I believe. We may have some more information about thromboembolism. But there currently are no, well, actually, that's not true. In April, there were now recently published joint ASH, ISDH, International Society for Thrombosis and Hemostasis, pediatric VTE prevention guidelines. And they specifically say for critically ill children that we should not administer routine anticoagulant thromboprophylaxis because of the absence of sufficient trial-derived evidence and significant confounding and bias from observational data that do exist. Go ahead, next slide. In adults, that's actually not true, and the rate of VTE is about 1 in 5, and as such, and because of pediatric trials that have been published, it is recommended for all critically ill adults without a contraindication. Clots are typically thought of as being more likely amongst patients who have a combination of risk factors that are the triad of Virchow that have to do with hemostasis, immobility, endothelial injury, and hypercoagulability, all of which are present to some degree in critically ill children. Next slide. And by and large, the biggest risk factor is the presence of a central venous catheter across all different pediatric subgroups that have been studied, from children with malignancy undergoing chemotherapy to children with critical congenital heart disease and other populations. The presence of a central venous access device is important, and that the clots are actually not necessarily in the vessel themselves, but can be intraluminal, which is considered an acquired venous thromboembolism. So every time you order TPA for a patient, that's actually a symptomatic VTE. You had to stop something. You can't give medicines. You can't draw labs, and you have to administer a medicine that has risk to a patient to open up and use that line again, or worse, have to take the line out, etc. We actually have recently shown that those are associated with the subsequent development of a clinically symptomatic VTE in patients. Next slide. And that the second most common risk factor is actually inflammation. So a parainflammatory condition or systemic inflammatory condition or infection are the most common. And these are some of the different factors that are associated with those types of infections that result in those increased prothrombotic factors related to Virchow's triad. Next slide. I don't want to go into too much detail here. When we've looked at this and developed a number of different models that have been now prospectively validated in a multi-center fashion, you can click once and it'll highlight because otherwise the slide's kind of a pain. But across critically ill children in multiple different contexts, the presence of a central venous line, length of stay, and a significant infection are not surprisingly the risk factors which highlight a high VTE risk in critically ill children. Next. And they show good calibration and good discrimination across a number of different ways that we validated this. Next slide, which we have. And most recently in a Blood article called that evaluated the Children's Healthcare Advancements in Thrombosis, or CHAT Consortium ICU RAM, in many thousands of patients, we validated this prospectively across 40 centers. Showing, or 32 centers, that in fact those risk factors are discriminatory for VT and can be turned into a scoring system that can be used at the time of admission and every subsequent 72 hours dynamically to assess for VTE risk. Next slide. Now, with all that said, when we look at case control data, large case control data about what's the efficacy of our prevention, and prevention are typically thought of between two mechanisms. One is mobility or mechanical thromboprophylaxis, and pharmacologic or chemical prophylaxis with usually low molecular weight heparins. And in this study, we actually stratified patients by the presence or not of those risk factors that we already mentioned. And the bottom amongst high risk, hospital acquired VTE risk patients, if you click one more time, it should highlight. If it doesn't, that's fine. Then go back, please. Sorry, Kristen. What's notable here is that only the presence of pharmacological thromboprophylaxis actually results in a risk reduction in VTE that's observable, not mechanical thromboprophylaxis alone. And that's across all risk tiers, including patients that don't have any of those risk factors. And these are all adolescents who would otherwise be eligible for mechanical thromboprophylaxis. So this kind of highlights that there's a 5-fold risk reduction for patients who receive pharmacological thromboprophylaxis, according to observational data that still require prospective validation and definitive phase 3 trial, which we're actually working on. Next slide. In the meantime, the concept has to be about net clinical benefit. We've told you all about clotting, but not a lot about bleeding. And patients are significantly at risk for bleeding at the same time that they're at risk for clotting. And balancing that, the attributable risk of a bleeding event related to an anticoagulant, balanced by the risk reduction in a VT, is actually the decision to be made, and it's actually not studied. Next slide. Which is why there's a lot of equipoise and uncertainty and perpetuating behaviors like adapting adult guidelines onto children, which is actually irresponsible and requires us to really be pursuing clinical trials. These are the clinical trials to date that have been performed. In the center are the ones related to critically ill children that don't have cardiac disease or an underlying malignancy. And they are phase 2 trials, largely underpowered and equivocal. Done in heterogeneous populations, restricted to very specific risk factors and endpoints, therefore making them not even generalizable to our patients. So we have some work to do. Next slide. And because of that, we think that identifying unique patient populations where there may be specific interest or unique risk factors that might be mitigatable are important, and that's where Kristen DeMayo got her research idea. So I'll let her take it away.
Yes, thank you for all of that background to set the stage to talk about the rest of this project. So just to review again, talking about specific populations or populations that are potentially at risk or we think are at risk for venous thromboembolism, critically ill children with diabetic ketoacidosis are thought to be at higher risk for thrombosis. It's thought to be potentially related to acute dehydration, severe metabolic acidosis, and hyperosmolar, like higher viscosity of their blood and being hyperosmolar. So we sought out to identify unique risk factors for venous thromboembolism among this specific at-risk subpopulation, kids critically ill with DKA, as it is still a knowledge gap. So this is where virtual pediatric systems really comes into play. Utilizing a multi-center database can really help evaluate potentially infrequent outcomes. Our research team had done a study previously using an administrative database in this same subpopulation, critically ill children with DKA. And we found a VTE frequency of about 0.3%, so a more infrequent outcome. But the big takeaway there is that administrative database really does not give us a lot of clinical data about these patients, and there's really not much more we can say about these patients outside of the VTE frequency. And so using virtual pediatric systems and what I'll get into is all the data and examples that we have really can give us a much more meaningful insight and look at this population from this perspective. So benefits of working with VPS, I'm kind of alluding to, again, a multi-center database with a large number of patient encounters that we can extract from. From the data collection perspective, understanding how well this group does this and the work that goes into this, we can get granular data, patient-level data, and I will show you some laboratory values and clinical scores and things that we can use to really help us learn more about the risk in this population. Timing of events and therapies, we can definitely get more information on that as well, utilizing VPS than we can in an administrative database. And then, of course, one of the great aspects that Dr. Sochet and I both really enjoy is the team-based approach to this, working together with the folks at VPS and together in a team, and really can make this work more meaningful. So I'm just really going to go through some examples and basically integrate some examples of the benefits with some of the project itself and the study itself. So I mentioned the numbers of encounters. And so for our population, we were able to gather over 50,000 encounters with our exclusion criteria. And this is over a 10-year period. Compared to the prior study that we had done with the administrative database, we were able to get around 20,000 encounters. So this just about doubled that, a little bit more. And then you can see here at the bottom left of the diagram here that, again, this just shows the infrequency of the event, 72 patients out of 50,000 plus. But again, we're still able to get a lot more meaning out of this data because we worked with VPS. So For the granular data, splitting this up into our primary outcome and secondary outcomes. So the primary outcome was the VTE frequency. We can look at the type of VTE. We can look at more at the encounter level, the timing of the VTE, the location, and its relationship with the central venous catheters Tony was talking about. And we can also look at regional and annual trends. So I'll have some examples of this in here, but it's great data that we can get about the outcome frequency. And then for secondary outcomes, of course, we can look at all of the known prothrombotic risk factors, which you guys will see in a table here shortly. And then we can also take a deeper look at the DKA-specific risk factors on such a large scale. So we can look at markers of cerebral edema or patients that are thought to be having cerebral edema, which is a high-risk complication in this population and typically signifies, sorry, I went too far, signifies potentially a more severe case or more severe DKA or more acidosis in these patients. We can look at the plasma glucose on admission, and we can look at markers of metabolic acidosis, all of the factors that are thought to be potential contributors to VTE in this population. So benefits of working with VPS from a granular data perspective, really the pediatric risk of mortality score here is where we could get a lot of the granular data that we used to look at. And so from top to bottom here on the left-hand column, we can look at the pH, the serum pH, the serum bicarbonate, the serum glucose of these patients on admission, and then their worst Glasgow coma score during their hospitalization. And the Glasgow coma score is the score for mental status for these patients. Other granular data and the way that we can evaluate it. So we can look at trends. And for here, I put our trends of admission acidosis and serum glucose or hyperglycemia. And so here's a really nice way that we can look at the patients with and without VTE. So patients with VTE in the green line, patients without VTE in the orange line, and we can at least make some comment on the trends here. I will show you all that later on with the granular data. There was no statistical significance with the level of glucose, serum glucose, and acidosis, but we can still comment on trends. And so here you can see that in the green line up at the top, the pH is on the lower end more frequently than those without HAVT, and then same on the bottom from the serum glucose perspective. On the green line, as it extends to the right, you can see that there are more patients that had those higher serum glucose levels. Here's another example of timing. So we can have a nice graph from our great team that shows us the timing of the VTE frequency from admission, so the days from admission that the VTE occurred. So this can also be commented on in a much more substantial way than trying to comment on something like this from a database perspective. Or I'm sorry, an administrative database perspective. So I commented on the team. I included Jamie Palumbo and Gerardo Soto Campos, their photos that are on the VPS website here because they were just phenomenal working with us. And I know Dr. Sochet had worked with them previously on some other projects, but this was my first time working with them and it was fantastic. So things we like about working with the team is that it's interdisciplinary. And so there's different skills and experience and viewpoints that we can add to the project to make it more meaningful. We had very frequent meetings. We did a lot of adjustment to study design, and we did a lot of troubleshooting. And then again, just the statistics that I'll show you shortly are just they can add more to the content of the study that Gerardo and Jamie were able to provide for us, especially with such a large volume of data. So here is the multivariate logistic regression of the risk factors for VTE. This includes both known prothrombotic risk factors as well as DKA-specific risk factors. So I'm not going to list every single one here, but the top 8, 10 are known prothrombotic risk factors. Here in the middle, presence of CBC and sepsis are right next to each other. And as you move to the right, you can see those two risk factors are statistically significant in this study for the development of VTE, and that's when accounting for all of the other variables. Down here, you can see the DKA-specific risk factors, the high glucose, the low pH, and the degree of the pediatric risk of mortality, in which some of those values are derived from that I mentioned earlier, as well as the cerebral edema composite. So no statistical significance found for any of those factors, but we are able to comment on trends, which I can show you here as well. I mentioned earlier, but this was a great addition to the study. The receiver operator curves for some of this granular patient level data, including the pH, the bicarb levels, the serum glucose, and the Glasgow Coma score. And so these were great to have for the study, that although there wasn't statistical significance for true association between some of these lab values, we still can comment on their potential positive predictive value of developing a venous thromboembolism. And it gives us more to talk about understanding that children who come in with more severe evidence of more severe disease still may be at higher risk than those without. So just to circle to the end here with the outcomes and conclusions of the study. So again, the primary outcome I mentioned are VTE frequency in critically ill children with DKA on this multi-center database with a large cohort still was 0.3%, and it was consistent with our prior study. For our other outcomes, both central venous catheter and sepsis or concurrent infection were independently associated with the development of VTE. There were no other DKA-specific risk factors that were associated with the development of VTE, but like I just mentioned, there is some indication that potentially more severe DKA markers may represent a higher disease-like burden subgroup that may be at higher risk. And of course, as Tony has alluded to in some of the background, we do need more studies for preventative strategies to identify some of these populations and continue to identify these VTE risk factors so that we can come up with study and come up with strategies that are generalizable to a multitude of populations. And I'm going to comment on what Dr. Sochet is going to be doing moving forward, as was alluded to in the beginning. So he's taking a great look and focus on VTE risk, development and prevention, especially in children who undergo invasive mechanical ventilation. That is another known prothrombotic risk factor that Tony has identified previously in some studies. And here are some studies listed in which folks that, although I'm not in these specific research teams, it's our entire team together that works together and bounces ideas off of each other to make our projects great. So I just wanted to give give Dr. Sochet's studies a shout out. These are studies with VPS and just, talk again about that team mentality that we have. So that's really it about my study. Here's my email and Dr. Sochet's email, and I already gave Jamie and Gerardo a shout out in the presentation, but some other of our collaborators here who are in, again, interdisciplinary fields, ICU, and hematology. And so it's just great to have such a good interdisciplinary team of folks working on this together. But thank you all for listening, and I greatly appreciate it.
Kristen, thank you very much. And Anthony, thank you very much. I think that for one thing, we're very close to our end, and we may have time for one or two questions, but I think from the VPS end, if the audience has questions that we don't have time to answer, if they would please send them to us, and we will get in touch with Kristen and Dr. Sochet and see if we can get them answered for you. So let's see, do we have any questions showing up here? I'm not sure I can pull up the list if there is. Since I don't see anything showing up on my screen, which doesn't mean that there aren't any, Kristen, I want to ask you a question, is that this was a study that you got involved in as a resident, and what kind of problems did you run into? I know you were working with a well-experienced team who's had a lot of experience already with VPS, but what kinds of things did you run into on your end that you kind of got blocked for a bit or had to work around? Because I think we have a lot of people, and we have oftentimes fellows and residents on this call, as well as some of the data coordinators. And I think having you try and identify things that you might expect are helpful. So
Yeah. Yeah, something that comes to mind is kind of a little mantra I have now, which is you don't know what you don't know. And so Tony knows that I just would constantly, ask questions when there were gaps in, study protocol and how to respond or what questions to anticipate. So really the biggest thing, or one of the biggest things for me is having a good relationship with your mentor, like open that you can ask these questions and feel comfortable as it's your first time probably doing a study like this and learning this world. You don't really learn this world in school. You just learn it by doing it. So that would be one thing for me is just be open with your mentor and have really, really constant communication. And Tony is really good at doing that with us as mentees. And then I think too, time management in residency is always difficult. And so just we talked a lot about just doing a little bit every day really helps you keep on your timeline goals and, to do the best that you can there. And so just trying to make a little bit effort every day, even if, you've had a long day or a long shift, you find that it's a little bit easier towards the end if you've made a little progress each day.
now I have a more difficult question for you. Have you already started thinking about your project that you have to have as a fellow?
I have. Yeah. We're doing it longitudinally trying to integrate the meetings throughout the year. Um, we're gonna see. We have some opportunities out here. I don't know if I'll do venous thromboembolism, but we have some opportunities for still some like high inflammatory patients, sepsis patients. So we'll see. But I'm always keeping in touch with Tony and the research team at All Children's. So.
Okay. And between either one of you, what kind of impact do you think this particular study has? I mean, obviously, you showed a lot of the physiologic data that you weren't able to do when you did the previous one, which demonstrated about the same numbers that were affected at the 0.3 level. But overall, was this what you expected, I guess?
No, not at all. Actually, Tom, we firmly came in with a one-directional hypothesis that the rate of VT in this population would be enormous because of our constant fear for sinovenous thromboembolism in this patient population, and the overwhelming bias that patients are very prothrombotic when they come in with diabetic ketoacidosis, whether it's from the dehydration part or the endotheliopathy. But as it turns out, by the time they come to the PICU, most of those things have actually been resolved. And so what's interesting is that there's a lot of selection bias. Most patients with diabetic ketoacidosis actually are discharged within 1 to 2 days. And in fact, many centers across the world, they're managed in the ER and sent home. And they aren't even admitted to the ICU, whether they're on insulin or otherwise. And so I think that what we did find is that among the patients who did develop blood clots, it's the same risk factors. So they probably are prothrombotic. They're probably immediately when they show up to the ER, they're very prothrombotic, which is why it's so difficult to place an IV in the patient and maintain it. They actually clot them off very often, anecdotally. And so that part's interesting. But among the patients who had symptoms, they had a central venous line, they had a co-infection, they had immobility, they had the factors that we already knew were prothrombotic. Now, we really wanted to hit on those like, man, maybe it's the degree of acidosis, the beta hydroxybutyrate levels, which actually we looked at in a single center study, some of the things that you actually can't sometimes see in registry-based or administrative data sets. But in this sense, the strength of VPS was the numbers. We're having rare events in rare children. And so that's really the benefit of using big data, getting that signal. And then now, unfortunately, because we deal with all of our patients are these kind of rare orphan situations, they are difficult to study. And one of the reasons in the beginning of the prequel to this lecture, there were so many slides about all these knowledge gaps and the fact we don't have trials. And some of that's just because we don't do the trials. It's not just because it's inconvenient. It's inconvenient to do them. It's expensive. But it's also that our incidence rates are so different, and the amount of patients that we need to enroll, amount of collaboration is so great that in order to detect a signal of reduction in this patient population and even account for safety is like impossible. And so we do rely on this may be the best data set that exists for many years to come in this exact population. And people will refer to this article when they ever think about, man, I wonder if DKA patients are hypercoagulable. They're gonna stop reading after they read the VPS article because
Well,
there's really not going to be anything else for many years unless we have enormous data sets that we can use, which very well might be possible. But for the time
right.
being, this is it.
It may be as things go forward. We have about not quite 2.5 million cases now in the VPS. And I would agree with you. I've been out of the actual clinical practice world for over 10 years. And well before that, at least 5, 6 years before that, studies would come out wanted to look at DKA and diabetes in the ICU. My ICU couldn't participate because the only patients that came in there had to have a pH that most of them were always well corrected before they got there. And so they went to
Yeah,
the floors where, yeah, they were sick, but they weren't sick enough to be in the ICU. So, I mean, you had to have a pH of, 6.8 or something like that, and
yeah,
cerebral edema already before you could get into the ICU.
yeah,
So it's progressed a lot, and population for our ICUs is not the same group of patients it was 15, 30, more than that for some of us.
I believe
We
for
don't,
sure.
diseases that we don't see anywhere now.
Yeah.
Anyway, again, I would like to tell the audience that if you have questions, please send those to us, and we will make sure they get to Kristen and Dr. Sochet, and I'm sure they will be glad to answer them in the future. Again, thank you very much. I'm sorry we don't have more time to have more questions. There usually are questions, but it takes a little while for the audience to kind of distill them and get them into the writing. But again, thank you both very much for joining us today, and good luck with your future endeavors.
Thank
Okay,
you so much for having us. I really, really appreciate it. This
you're
was a
both
great
Thank
welcome.
you and the team from VPS. Thank you. Bye.
Thank you, Anthony.
Bye.
Bye.